Good morning. My name is Dr. Hershey, and this morning I'm presenting Boots on the Ground, Opioid Management in High Utilization Areas. The goal of this talk is to give some broad strokes on theory, but most importantly show an example of how theory was turned into practice. I will outline pieces of our build you can modify for your own use and initiate as early as your next clinic day. For the sake of time, however, I won't be able to delve into specifics and details of each template and form, but all will be made available to you to download online through MAFP. I have no disclosures, conflict of interest, or honorariums to report. So the story that led me here today started in 2014 when I actually started as a fledgling medical director of a rural outpatient clinic. Well, two to be exact. The main clinic was within the hospital in Eaton Rapids, and then there was a satellite clinic in Jackson County. So, in full disclosure, I took this job as medical director despite knowing that they had great rural reimbursement rates, but were somehow losing about $500,000 each year. So, when I'm often asked why I took this job, I can confidently say that 1, I am clearly challenged in making good career choices. 2, the state loan repayment for rural site was ever so shiny. And 3, I thought I had enough business management experience from my pre-medicine life to try to maybe improve the financials. And in all honesty, perhaps it was cockiness, but frankly, I didn't see how at the time I could make it worse. And even if I didn't make it better, I was thinking I could just blame it on my youth, recede into the bushes, and run back to the city. So what could be so bad, right? But what I didn't know at the time was that the outpatient clinics in Eaton Rapids and Springport were kindly referred to as candy clinics by the locals. There was little to no structure on prescribing or managing controlled substances. 4 physicians in the surrounding communities were under federal charges or in prison for their prescribing. And this beautiful road called M99 that I drove in from Capital City to my new job was apparently a haven for drug and human trafficking between Ohio and Michigan. So after making variations of these spaces for around roughly a month, I thought, okay, I can't take any more wrinkles on my face. So I got to figure out how I can survive this 2-year loan repayment commitment, not lose my medical license, hopefully not end up in jail, but still treat these patients in the community that have been overprescribed for so long. So I did what most type A people who can read do, started trying to create a plan. I read anything I could get my hands on back in 2014. Anything I could find with the combination of words non-cancer, outpatient, or opioid management I consumed. Some of the most influential and cited research were from Canada, the Veterans Association, a few state programs, the CDC, and some university sites. For light bedtime reading, I read Cases Against Doctors by the DEA. So what I found in a nutshell was that there was support that opioids were being highly utilized. And there was this growing body of evidence saying that chronic opioid use wasn't the best in non-cancer pain management. But where the two met in the middle, in terms of what providers should do, there wasn't a lot out there. Thankfully today, we can actually find lots of tools to implement reduction and utilization, including this presentation. But know that there is still not the randomized control trials and the longitudinal studies to back up these recommendations. These are at best expert opinion, and hence why opinions on tapers and variations on guidelines also vary from state to state and organization to organization. You see, the reaction by legislation is varied also based on state demographics, what research and organization recommendations they're focusing on, and the varying public pressures to act. As to providers, we are all somewhere in the cycle of grief, I think. Whether we're pretending nothing is happening and functioning normally, quote unquote, in shock and denial with a few sprinkles of confusion, anger and irritated, wanting to punch anything that comes in sight, depressed and overwhelmed, asking, why me? Bargaining and retelling our woes to anyone who will listen, or in this rare acceptance stage with some plan in place. Frankly, I think this is the best we can achieve at present, but maybe someone out there has returned to a meaningful life stage again. I just have yet to meet them. Based on my demographics in Eaton Rapids and Jackson, I had to act sooner than most in the state. I think I can say I have graduated mostly to the acceptance stage with some occasional and horrific spirals, but Yeah, mostly I think I'm at the place where I can see some light at the end of the tunnel. And hence, that's probably why they asked me to present today. Essentially, to get here, I had to commit that we and myself were going to do something to decrease utilization in our outpatient clinics. And whether this came at a cost financially to the hospital or at cost to my job, it was something that I felt I had to ethically do. So if we fast forward 2 years, I'm going to detail to you all the things that we did in those 2 years. But first, I want to tell you what happened after we implemented our plan in 2015 and all the way up to 2017. So this is my happiest slide. I can say by 2017, we had created a sustainable opioid management program. We had decreased our prescriptions of chronic opioids from the thousands to a few hundred. We tapered hundreds of patients in the Eaton Rapids, Jackson, and Clinton County areas. We did not close the hospital or the clinic. In fact, our clinic patient population grew fourfold. We became financially viable 2 years post our opioid management program adoption. We actually started making a profit in August of 2016. And most importantly, I didn't lose my job. I can't talk about the successes, though, without also painting an honest picture of the cost of these gains. I made a lot of mistakes in those 2 years. Lots of embarrassing moments, especially as I was learning vocabulary to build trust with patients who came in wanting more opioids, but ended up leaving with a taper, for example. I learned and relearned communication skills beyond that was ever taught in school or residency, to confront some not-so-friendly perceptions of myself in the community. And if that wasn't enough, I had to tolerate having my likes lowered at times on social media. But most importantly, and still what keeps me up at night, is not knowing whether these successes will hold up longitudinally for patient outcomes. Simply, the research wasn't there in 2014, and it still isn't there now. But I'm hoping you can learn from my mistakes, but know that I have no cure or suggestion for that last piece. Despite being in some unknown territory, we can hopefully work together to shed light and build the evidence to support what we are trying to do. From here out, I will share with you evidence-based guidelines, in addition to my own anecdotal experience when the research is not there. I will share the philosophy, framework, and forms we used to get where we did. Then I will share what is currently being revised as a new model. Creating a philosophy was important because it was kind of like a mission statement for our entire project. We decided we wanted to create a safe, holistic, and evidence-based prescribing program. The evidence we used was that chronic opioids in non-cancer diagnosis did more harm than good. We utilized family medicine principles of the medico-psychosocial model, trying to partner with our patients in a holistic view, and then determine safety by patient safety, managing a multi-provider, multi-location structure, and employing advanced practitioners within the Eaton Rapids-Jackson area who needed more structure for prescribing. The framework I developed was based on purely my own anecdotal beliefs. I personally feel health literacy is something that is fundamental to making any sort of policy or procedural change in a clinic. Health literacy is defined as making essentially what we do in medicine understandable to our patients. That was the crux of our entire framework of this opioid management build. From there, we created policies and guidelines that helped create the backbone of our program. And after that, we developed maintenance structures to ensure that our policies and guidelines were being followed. For the sake of this presentation, I'm going to only be focusing on health literacy and the policies and guidelines, and very briefly on the maintenance piece. I will highlight some of the most important forms we used as we discuss the framework in greater detail. All of these forms will be available to you also through the MAFP site. As I said before, health literacy was such a critical foundational piece to our build. And being so, I'm going to spend a little bit of time on this stage because of how important it was for our framework. We pushed health literacy in all areas of our clinic, from our waiting rooms, clinic rooms, on the phone, and face-to-face, whether it was with a new patient or an existing patient. We felt that health literacy helped support every piece of our philosophy, and it allowed our entire healthcare team, including the patient, stay focused on common goals. So I'm going to break down health literacy into two categories, passive and active. Passive health literacy is what I describe as things that are educational for patients to read that or view without the need of a provider present. So we started our passive health literacy initiative in clinic rooms and hallways using posters and informationals. And then we expanded that to our new patient folders, websites. We made sure we put in our discharge paperwork in addition to videos on Facebook and on the Eat Rapid site. And then a few of the providers also did some pieces for the local newspaper. These are just some of the examples that we used as health literacy in the hallways, clinics, and waiting rooms. I essentially created these in a Word document, and it allowed me to tailor the education that I gave to the providers based on what I had made. Frankly, now there's just so much great info out there that you don't have to use these by any means. There's great health literacy forums from the CDC and from multiple other sites, which I'm going to link to down below at the end of the presentation. The tip I'd like to pass along is during these times of change of policies, laws, and we want to provide additional education on a particular topic, to really put that as your front and center. So during our initial phase of our policy changing for long-term opioids, we took down a lot of our other health literacy information to make this front and center. And basically the main pieces that we left on was what will my visit look like and our refill poster. Everything else was really geared towards focusing on opioid management. Then comes the active health literacy, which is the face-to-face with the patient. Now, this is what makes most providers want to swim in their chair and sweat themselves out of it. But I'm going to try to break this down into a stepwise fashion that we created essentially for any new providers to help ease them into having these discussions. So this stepwise fashion can be done in a 2-visit or a 4-visit approach, and it's best done for existing overprescribed patients. So if you have patient, let's say normal, who is taking Norco 10s 4 times a day, is coming in now hoping to get Norco 5 times a day, and you're thinking, oh, Norma, we are hoping to actually not have you be on Norco at all. This would be a stepwise approach that you could take to having this discussion. So step 1, and undoubtedly the most important step in this whole process, is to listen to their story. So Norma here, let's say, has been a patient of mine for 3 months or 3 years, it doesn't matter. And I'm thinking at this point, this chronic opioids that we've been prescribing is really quite inappropriate based on her diagnoses and her lack of trial of other modalities. So I'll be calling her in for an appointment to talk about pain management because she's called in asking for more pain medication, let's say. In that first visit here, the first half of that visit, for example, I would be reframing the conversation to say, Norma, it's been a really long time since we talked about what's happened to you. I really want to rehear from the beginning all the things that have happened to get you to where you are right now, because I can tell that you seem to be like you're in a lot more pain. This is really important because this is a time where you get to, you should listen, actively listening. Letting the patient tell their story. It allows them to really feel like you've gotten what their suffering has been like. And it's a great opportunity also to connect with the patient in ways that you probably had not prior, or maybe you have, but have forgotten their struggles, their challenges, how this has really affected their life. The second most important piece of this conversation comes to, as you're actively listening, you're teasing out either in real time or in a summary form examples of them describing their own functional decline or their worsening pain. So this is really critical because as they're describing their journey, their pain journey from either an accident, an incident, or the slow, gradual arthritic pain, they're going to start talking about how things have progressively worsened. This is something that a lot of providers are afraid to talk about because it leads to the conversation of needing to prescribe more. But the beauty of this piece is to actually tease these pieces out and highlight them, because it's going to help you make your argument for actually tapering them or to at least maintain their current dose. This is important because you're going to use the evidence-based research that's out there for the hyperalgesic effect of pain meds and the long-term side effects of these meds to make this argument. But thankfully, the patient is actually giving you all the cues to make the argument themselves. So step 3 is, now you've listened to their story, you've highlighted some of the areas where they have worsening function or increasing pain, and now step 3 comes along and you ask them, where do they want to be in 5 years? What do they want to do in 10 years? And what are they living for? In asking these questions, very rarely do people say they're living for pain management. They'll give more of a story that connects them into a meaningful relationship with somebody. Perhaps it's their grandkids wanting to play with them or walk their daughter down the aisle, something that's related to some sort of functional ability that they want to live for. Step 4 is then about legitimizing. You've now listened to their story, and it's time for you to tell them that you believe them. You feel for them, you believe them, you've heard them. This is such an important step because this is now leading into a larger discussion where you need to have built trust with this patient for them to start listening to you. Step 5 is then about education. I like to start this step by asking permission whether I can explain to them some of the latest research that's out there on pain management. I explain that my role as their physician is to give them guidance into the options that they have to choose. And they see me, hopefully, as somebody who wants what's best in their short-term and long-term goals. So once they've given me permission, I start on a model called the candle model. I explain to them that pain is not all treated the same, even though it's felt the same. The candle model is my analogy that I've created to explain nociceptive, neuropathic, and psychogenic pain. So I tell a patient, imagine there's a candle here, and I've burned myself on this candle with my finger. That burn would send a pain message through my nerve to my brain saying, ouch, you burnt yourself. And this is evolutionarily advantageous so we don't go around burning ourselves. But this burn pain is one type of pain. It's nociceptive pain. And nociceptive pain is actually really well treated with opioids. Now the second type of pain is there's no candle and we don't have the burn on our finger, but there's a nerve signal that keeps firing saying we've burned our finger. It goes from our nerve to our brain saying burn, burn, burn. This is neuropathic pain. This type of pain is not well treated with opioids, but rather with gabapentin, Lyrica, Cymbalta, Elavil, things like that. And then the third type of pain is psychogenic pain, which is there's no burn, there's no nerve signal, but the brain keeps interpreting as if the nerve is signaling it and saying there's pain. So psychogenic pain is very different from nociceptive or neuropathic pain in that it's the chemistry of the brain that's out of order that keeps making us feel pain. So that's treated oftentimes with agents that help to recreate that balance in the brain, such as an SSRI. All three types of pain are real and legitimate. All of them are often felt the same way. So from here, after you've explained the candle model, you want to explain to them that one of the goals that you have is helping them manage their respective type of pain. But also, and more importantly, you want to tie in the functional goals they have for them, for themselves, for later in life. So this is also, in my opinion, again, this is just anecdotal experience, I like to take this opportunity to build further trust by saying that in the medical community, we haven't necessarily done the greatest job in helping with function. Our pursuit for pain management in the last few decades has been at the cost of function. And we're realizing that the patients really want to essentially be alive. And based on your goals too, Norma, it sounds like you also would like to be alive and be able to be functional to see your granddaughter's violin recital, or whatever it might be. That's one of her functional goals. So this is step 5, education. very heavy on health literacy. At this point, hopefully you've built a foundation of trust and understanding with the patient that they will be much more receptive to hearing what you have to say. At this point, the patient may be very receptive and accepting of where this conversation is going, or they might sense the change and fall into another point in the cycle of grief. Confusion, anger, bargaining, etc. We as providers can compassionately address this, knowing their reaction is coming from a place of fear. The fear of change and the enormous fear of making their situation worse. At this point, I like to re-listen to their concerns and then state the emotion as fear. Stating the emotion often can help jolt the person, at least temporarily, out of their particular stage and back into productive conversation. Lastly, step 6 is explaining whether it's this visit or next that the need to address overprescribing will have to take place. You can recap by saying that you want to prevent hitting the proverbial prescribing ceiling before the end of their life, and that you want to improve their function, improve their mood, and help them feel more alive than drugged, or whatever it is that would help the patient reconnect to this philosophy. After step 6, we're going to be merging into the second phase of the conversation, and also changing from our health literacy framework to our policies and guidelines. Here, we're going to clearly lay out our plan, an implementation date, and then what within our policies and guidelines we're going to be following. I'd like to take a minute to describe the definition between policies and guidelines. Policies for a clinic should reflect what you're doing 100% of the time, and these can be based on laws, internal rules, hospital structure, but know that policies are what you're going to be audited against, and if you're not following your own policies, you will be cited. Guidelines, however, are recommendations for your clinic and its clinic providers to follow. These are not auditable. So, for example, in our structure, we put our prescribing recommendations, our validating tools, our pain contracts, and our tapers under our guidelines, and built our structure in that manner. So there are a lot of tools to use to determine efficacy and risk for opioid use in patients. We chose the DIAR, though, in our outpatient clinics. The DIAR is a validated tool specifically designed for primary care that helps correlate patient compliance and efficacy of long-term opioid therapy based on its score. It takes roughly around 2 minutes to complete and gives some objectivity to a subjective history, essentially. It looks at diagnosis, intractability of pain, the psychological risk, the chemical health risk, reliability with responsibilities, social supports, and how efficacious opioids have been in the past, essentially to give a score between 7 and 21. A score less than 14 gives support to a patient not being a suitable candidate for long-term opioids, and a score of 14 or above supports the possibility of consideration of opioid management. I think the DIAR also has potential to show a quote-unquote bona fide provider-patient relationship, but this would need to be explored further with research. So some takeaway points that I'd like you to consider based on what we did with our policies and guidelines is within your policies to have the MAPS check as one of your policies that you would have then an office manager create a consistent workflow for your staff. And this would also allow then for you to be able to ask for an internal audit to ensure that you're doing this 100% of the time. As to guidelines, I'd recommend that you incorporate the use of a contract, and within that to allow yourself to be able to do a random pill count or drug screen for any suspicious behavior, and then with the drug screen to offer a urine drug screen or a saliva drug screen. And I would also highly recommend the incorporation of these two screens during downtime in waiting rooms or clinic room. Then to consider prescribing caps or morphine equivalents as one way to structure your prescribing in your clinic. And then lastly, determine what you will and will not prescribe. For example, we decided as an outpatient clinic that we would not support writing for benzos for over 3 months, except in specified cases that were outlined within our guidelines. So as it comes to tapers, they're mainly utilized to assist patients who've been overprescribed to help them come off of these meds with the least amount of withdrawal symptoms that we can manage, or to facilitate patients who've broken their contract and need to come off the medication faster. So again, research is pretty fairly limited on the best way to taper, And few guidelines exist to help us do this. But research does show that if patients are stopped abruptly from their pain medication, they can experience some significant withdrawal symptoms, including increase in pain, hypertension, tachycardia, restlessness, sweating, nausea, cramping, diarrhea, sometimes a tremor, hot flashes, dizziness, shivering, insomnia, anxiety, mood swings, to name just a few of the many that they can experience. And these withdrawal symptoms can last 2 to 3 half-lives after the last dose. And then research also showed that they improve within about 1 to 2 weeks. So if the theory behind tapering is that if we reduce the dose slowly, hopefully we can minimize some of these symptoms. The goal in tapering also is to educate patients about expected symptoms and ways to alleviate some of these symptoms if they do arise.
So this is our routine taper, and this can be found on the MAFP site for you to download. The evidence that was and still exists support this tapering plan of 10% each week. However, note that some pain management specialists have argued it is too fast, and they made cases for a 3 to 12 month taper. Again, good longitudinal studies are not there to support either a 10% taper or the 2 to 3% per month taper. Lastly, the CDC and the newly minted recommendations from Mayo and Harvard do also support the 10% taper currently, but they've included the caveat that how fast you taper depends on how long the patient has been on opioids, the dose, and the number of medications the patient is taking. However, don't give any further guidance beyond that. This page shows our emergent or rapid medication taper. The recommendations here for this taper are to decrease by 15 to 33% a day over a 3 to 7 day period. This taper is supported by the current evidence, though it is limited, and should only be used, in my opinion, for cases of concern for overdose or illicit drug use violating the contract. This taper is harsh, and without a drug rehab program to support, can be very challenging to a long-term opioid user. In both the routine and emergent tapers, you'll find at the bottom symptom management info. We in our clinics recommend patients to call us if they're experiencing any of these to get additional help from us.
Recently, I've started looking at a new framework in which to help with furthering and improved guidelines for prescribing, taking into account the life spectrum from the perspective of longevity goals, functional goals, and comfort goals. I think this particular framework, which I've adopted from the National PACE Association, will be a better fit to meeting patients' need based on the philosophy of safe, holistic, and evidence-based prescribing. As I continue to work on this 4-pathway prescribing guideline framework, I appreciate a number of things it has to offer. 1, it takes into account where the patient wishes to align with criteria and respective goals. This allows for improved shared decision-making with the provider. For example, if I want to improve my function as much as possible and live for as long as possible, I'd likely align myself with the longevity pathway. Within that pathway, I understand that I must be willing to withstand some discomfort to pursue longevity. The goals of this pathway include the following in terms of priority. 1, prolonging life. 2, increasing function. And 3, minimizing suffering, in that order. However, if I wish to pursue maintaining function and allowing my life to run its natural course with minimal intervention, I would likely align myself with the functional pathway. This pathway's goals are to 1, maintain function foremost, and then 2, minimize suffering. These pathways, I believe, can help tailor discussion, care, expectations, and also not assume that a one-size-will-fit-all in pain management through the spectrum of life. This is still a working template and has yet to be trialed in a clinical setting. Lastly, we come to the maintenance stage of the build, but due to time, will not be able to be discussed in detail. But after you've done your build, you'll want to test and secure it with internal audits, patient surveys, and continued education for your own patients and providers. Expect the need to tweak with new research and changing patient population needs. But know that the overarching goal of this stage is for all parties involved to come to the quote-unquote meaningful life stage through the continuum of this journey. However, as we travel together, I am honestly very hopeful that it will lead us to a better destination as both primary care providers and as future patients in the system we build. So in conclusion, please use these tools or other tools. As I said, there's some really great ones that are out there, which I'll link below, to help you start your opioid management journey. Know that with all the poor choices I've detailed, I've already made in my medical career, that if I can do it, most definitely you can too. Expect to modify with further research as it comes down the pike, as with any area of medicine. And then keep your eyes and ears open, both in the clinic, with legislation, and with standards of care. This is an ever-evolving field, and the landscape is quickly changing. Lastly, I have to put a plug in for the MAFP Advocacy Committee, which I've sat on for the last 2 years. Essentially, I hope you'll join us in advocating for yourself and your patients for more evidence-based research, more drug rehab programs throughout Michigan, and more covered programs for our patients. Thank you for your time and for listening this long.